So this is a balloon inflating, right? The balloon inflates, it actually inflates and covers the tip so that it is well protected. It's not going to damage structures. It's not going to get caught in the chordae tendineae of the right heart, right? So it's sterilely inserted, obviously. There's a sidearm cordis that we have to make sure has fluids going through it at all times. The Swan is flush, so we make sure we're getting a catheter that has no air in it into the patient. The sterile sleeve is placed, make sure it's placed in the correct orientation, right? So our sleeve is placed over and locked right there, and then it's kind of, this little sheath here, and then we kind of secure the other end. There's our PA coming out the other side, right? So that sterile sheath needs to be placed before the Swan is placed, because it's hard to get that one sheath over five different lumens coming out, right? And then the balloon is tested, right? You never put saline in this. It's all just air. It's not helium or nitrous or anything. It's just air. And again, it's 1.5 cc's. The little delimiter there, so we don't give more. And it's inflated while you're advancing. So first you advance it till you get to the right atrium. You'll see your right atrial pressure, and then we're going to inflate it once we set right atrial pressure, and we're going to float it in the RV. We see the RV pressure, and we then float it to the PA and see a PA pressure. Okay, and then we inflate it again, then we deflate it and inflate it again to see our wedge pressure. So how do you know you're in the RA? Usually you're about 20 centimeters to get to the RA. So there's markings on it. So that'd be which markings? One big, one thick, one thin, two thins, two thicks, well, two thins, right? So two thin lines on our catheter here. So this is like 70 centimeters, right? That's 60 centimeters. And then so we want to have two thin markings, right? Because the small is 10, right? And the thick is 20. You can't read that at all. All right, so the insertion process. So it's inserted by cardiology or by anesthesia, and they're going to advance this at least about 20 centimeters, right? We insert it via the catheter here. So see here I got our sidearm. I would like that flushed personally, but they're going to invite it. They got 30 centimeters there, so they hit probably 20, right? So they're going to invite 20 centimeters and look at our waveform. It's going to turn to a CVP tracing, and look at the little PAC they got as he tickled the RA, right? So that's inserted all the way to about a nickel, or a reading of about a nickel, about 5 centimeters of water, because that's what our normal CVP is, right? So the balloon can now be inflated, and then we can now advance it to the RV, right? So we get our classic ACV, right, and our XY descents, just like we're used to with CVPs, right? So we're right here. We are getting our classic CVP waveform because that's what this is. It is a CVP tracing. So we're right here currently. The next step is, again, we're going through the sheath, right? The sheath doesn't go that far, but then we now are in the RV. We've inflated the balloon, and now it is being floated down into the RV, right? The RV pressure looks like what's it called? Like an arterial line pressure, but there's a little bit of differences because, as we know, if we're in the RV, if you imagine yourself right here, and that RV is filling with blood during diastole, that pressure is going to go up on that diastolic limb. We see this upward deflection because it's filling with blood. Whereas if we were on the other side of the valve, it would be going down as all the blood went into the periphery or into the pulmonary circulation. So that's one of the clues. You have a catheter that's migrated or a catheter that's in the RV, is you have this upslope in that pressure, right? In that diastolic limb. The other clue is that you are in the RV, is that you have a low pressure, about 5, right? Because the pressure go all the way down to 5, and then the CVP is going to fill it up, right? The RA and the RV match at the end of diastole, right? So if your diastolic number on your monitor is 5, right, and the high number is 25, because we have to squeeze up to 25, right? That's going to be our PA pressure. So if we're all the way down to 5, so it was a higher number compared to a lower number, that's a big clue right there. And you can scroll back on the monitor to see, oh look, it migrated right here, right? You can see that they have a migration. See this big difference right here from a PA pressure versus a RV pressure. The only two differences are the PA diastolic is lower in the RV, and it's also uptrends in the RV. So those are our two differences. The RV pressures, again, the low pressure is going to be a nickel. That's what it was in the RA. And our high pressure is about 25. That's what it's going to reach. Okay, so you're going to be advancing about 5 to 10 centimeters, and that's going to be getting into the RV, right? Note the change from an CVP waveform to this RV waveform. See how it changed up to 25 points? but it's still all the way down. It hasn't, the baseline diastolic has not changed. It's still 5. And then now we're going to be migrating all the way to a familiar situation, right? We're going to see our dichrotic notch, right? Comes home, and there we go. There it is, dichrotic notch. We have that closure of the valve. And yeah, that can be what we kind of assume it is, but it is truly a deflection from the periphery against the valve. All right, normal is about 25/10, right? So again, it's not 5, because if it was 5, we would be in the RV. So 10 is usually where we're at. That's usually a normal. If it was all the way down here, that would be a RV waveform. That would mean our catheter has migrated back into our RV. How do we know it's in the RV? Well, if it's in the RV, it might tickle the RV and cause the PVCs, or we'll see our centimeter marking on our catheter. We'll see that it's migrated back about 5 to 10 centimeters, or one thin line. Okay, so it's like the thin line. Anyways, we have what else? You'll see it change from 25/10 to 25/5 if you had migration, or you'll see that upstroke happen that you see with RV pressures. You don't see that with a PA pressure or with an arterial pressure for that matter. Okay, so you can see going from the RV and look at the change in the baseline. See that change there? That's how you know you're in the PA and not the right ventricle. And usually we end about 40 to 50 centimeters, right? Use about 20 centimeters to get to the RA, 10 more centimeters to RV, 30 centimeters, 10 more centimeters to get to the PA, right? All right, and then the final piece is wedging, right? So now we're in the PA, and now we're going to inflate the balloon, right? When we inflate the balloon, we are going to block all forward flow, and now we're going to be listening on the other side of that balloon to the other side of the heart. So literally we inflated the balloon right here, and now we've occluded everything behind it, and all that we're hearing is silence, hopefully, and everything translated from the left atrium. Just like how we transduce in the radial artery, and we are then going to feel what's going on there, we're doing the same thing here. But it's not 300 millimeters of mercury, it's 1.5 cc's of air, right? And now we are listening to the other side of the heart, right? So we're literally listening to this left atrial oscillations, right? And the left atrial pressure looks exactly like the right atrial pressure because it's sitting in an atria, right? The valve is going to close, AV valve is going to close, it's going to fill up, and then you're going to feel that contraction as the ventricle on the other side. So you have the A, C, V, and X, Y descents. It's exactly the same. The only difference is it's a little bit higher because it's the left atrial system is a little bit higher in pressures, right? So it's about 10, like a dime, instead of 5, like the RA, right? So note the centimeter marking to make sure that we are not migrating any further, because this can migrate with someone getting hot, right? It can start migrating further into the PA. So that's something to be considerate of, right? And again, a chest X-ray is needed to make sure the PA is going the right direction, and it should be on chest X-ray in the lower lung fields, and we'll point that out. Okay, so you can see here he has the PA waveform, and then it's going to go right down to a lower waveform about 5 centimeters, right? How do you know it's not in the RV? How come it didn't migrate backwards? Because we don't have that classic upstroke like we have with a RV or PA pressure, right? We get this ACV wave just like we have with the right atrium. The only difference is that it is elevated compared to the CVP. All right, so how does it wedge? What does it do? Again, it's just like a cup and string. If you ever had this pastime as a kid when you didn't have internet, right? So this is where you listen to each other via a string, right? And you can hear the other side of the heart. So we just inflated everything, and now we're just hearing the oscillations from this side, right? The lungs, yes, are in the way, but we want to make sure we have a nice fluid column. And the best fluid column is in zone 3 of the lungs, right down here. That's where you want it to be. If you're all the way up here, then the pressures from just breathing or from the ventilator can interfere with my pressures. I'm not going to get a good waveform, right? I'm not going to get a good value. So how do we know I have a PA pressure? It's going to gone from a PA pressure of like 25 over what? 10 to about 10, right? So it's gone down. It looks like a CVP tracing. It doesn't look like an arterial tracing anymore. Okay, so proper lung zone is appropriate. There is 3 zones of it. We want the bottom zone. That's where it's ideal. And an X-ray can help can confirm that. If they place that in a fluoroscopy and cath lab, then they can definitely make sure it's in the right place. All right, if it's not in zone 3, there could be a lot of respiratory variation. All right, so then waveform changes from baseline, right? So that's what we're assessing at all times. Make sure our catheter is nice going down right there. See how it's going down to these lower lung fields? That's what we want to see, right? Here's our catheter going right here, and it's going to the right side. It's okay if it's on the right side or left side, as long as it's beyond the mediastinum. That's usually what they say, right? So it's about within 2 centimeters of the hilum. So the hilum is this situation right here, like the mediastinum basically, and it should be about 2 centimeters beyond that. If it's further beyond that, that might be concerning, as in maybe in too deep, right? So we want to make sure we are always assessing the waveform, that it's not turning into a CVP tracing. That's not good, especially if it's at 50 centimeters and it's CVP tracing. That's not, we know the RA is 20 centimeters, right? 25 centimeters maybe. It would never be, you got to kind of put 2 and 2 together. So I look at my centimeter marking and look at my waveform, and that tells me if I'm in the RV or the PA, or if it's maybe migrated into the further down into the pulmonary artery. Okay, always make sure your balloon is deflated. It's always empty and it's always open, right? Meaning that it is not closed. Because if it's someone closes it, you could have left behind 0.5 cc's, and now a clot can form or something bad can happen. Okay, and normal maintenance, make sure we're locked in place so that it can't migrate on us. This sheath should come with the patient so that it can be migrated by the physician or the provider, right? We can always pull out, right? If we are removing a swan, we never advance or float swans. Okay, what are complications? Just like eclampsia, infection, bleeding, pneumothorax, air embolus, arrhythmias, right? As it migrates to the right ventricle, can start causing BTAC, right? Right bundle branch block we mentioned. If they have a left bundle branch block, probably not a great idea to put it in, or they're very, very careful to make sure we don't cause a complete heart block. All right, and then they may need a transvenous pacer. If we placed a swan that can do pacing, you're already set, right? That you're already well ahead of the game. And clots can form, right? DC in about 3 to 7 days. Just try to get them turned around if you can. It can rupture the pulmonary artery, especially if you overinflate the balloon. So that's why sometimes some providers say don't even inflate it at all. Just use the PA diastolic, because we said the PA diastolic was 10, right? And the PA pressure is 10. This is only accurate if they don't have pulmonary hypertension. If they have pulmonary hypertension, that's hypertension on the pulmonary side, on the RV side. So you can't say that's the same number on the left side. But if they don't have pulmonary hypertension, it's okay just to use it as a substitute. And what are the pulmonary problems? You get a PE infarct due to clotting. We can get valve damage. So that's why we say if they have a mechanical valve, we're not even going to bother, because you might pull a valve out with you when you pull out the swan, and that's frowned upon. And then the mechanical nodding, about 1% of the time. That's usually with error in technique, where they advance, like it's not working. And then it advances on itself, advances on itself, advances on itself in the RA. And remember we say we should be about 20 centimeters to the RA. So if you're like 50 centimeters and then you still have a right atrial waveform, well, it might have looped on itself, and now this was in 1992, the last documented case. So don't be the new case of where this happens, or witness it at least. Okay. And right bundle branch versus left bundle branch block, we can talk about that more as an aside. But in V1, that's usually what tells you the difference, if you have a left or right. In V1, if it's positive deflection, it's always a right bundle. In V1, if it's a negative deflection and wide, it's always a left bundle. There's no other tricks or trades out there. Oh, and you got a sleeve rest 2 segmented in V6. No, that doesn't make any difference. It's V1 is what tells you the difference. All right, so don't be a party trick where you're trying to tie off your PA catheters. All right, so a quick summary, right? So you just use the change analogy. So I'll give you little cards here that has a change on it, and you can see the difference in our different pressures there, right? So we know our CVP from our CVP portion was 5-ish, right? About nickel. And then we go into the RV, it's going to go up to 25 over a nickel. And then it's going to go to our PA, and it's going to raise to 25 over a dime. And the dime's going to keep for our LA, or left atrial pressure, or our wedge, or our pulmonary arterial occlusive pressure, or our pulmonary capillary wedge pressure, or our wedge. So there's all kinds of different names for it, but it is achieved by wedging, right? And then now we can start getting other fancy values. We can start getting our cardiac output, cardiac index, pulmonary vascular resistance, systolic vascular resistance, our workload of our LV. You can estimate your stroke volume once we have these other numbers. Once we have the wedge, once we have the CVP, we can start getting more values, right? We get more hemodynamics. And that's the next step, is finding our cardiac output, right? And then also remember that you have to measure this accurately. It needs to be done at end expiration, right? So it's vent for valleys, is the valleys, and if they're vented, and it's the peaks if they are not vented, right? It's why do they have a swan if they're not vented? It's kind of hard to validate, but maybe it might be just on the fence, okay? And then where are we at next? How to wedge and how to CVP, how to get this CVP tracing, right? So we go from a PA tracing to a CVP tracing. It's the CVP of the left atrium. So that's what you're looking for as you are inflating this balloon right here. You're inflating. It might not need all 1.5 cc's. It might only just need 1 cc. If you put in all 1.5 and it doesn't inflate, you don't get another syringe and do it again. It means it probably migrated out of the pulmonary artery. Okay, so make sure everything's level, everything's good, you're ready to go. And then there's a special screen on the GE monitor where you select wedge, and it says, hey, you ready to wedge? You want to do it automatic or you want to do manual? So automatic means you inflate it and then it automatically detects that drop. You're still observing it, and then it will punch out a wedge for you. Whereas manual is you do it, you see the change, hit freeze, and then you can then find your exact waveform. You can move the line over to see, at that C wave, which is what you should get for all CVP tracings, right? So remember, when you're done, you're always going to make sure the balloon passively deflates, disconnect, let it deflate more, and reconnect. And you leave the stopcock open. You don't want to, because you don't want to make sure, because sometimes there maybe could have been some air left behind. You don't want to leave that air in there to be a breeding ground for a clot of some sort, right? Verify your waveform is good. Make sure you have a PA systolic, a PA diastolic, and a 25/10. It should not just be like 10. That's not a appropriate waveform, right? And record the CVP if you haven't already. Usually do it first, but you can do it afterwards if you haven't remembered, because you need a CVP to get your SVR, your systemic vascular resistance. All right, so if it's not wedging, what do? You're looking for the tracing. Again, if it doesn't change to our classic CVP tracing, it may have migrated out, right? So do we need to migrate it back in? Well, we might be able, you can, they still have the sheath in place. That's the provider can come in and they can migrate it back in if they need to, or they can decide if they still need it, or they can decide if, to just use the PA diastolic, right? So when I can just use the PA diastolic as long as there's no pulmonary hypertension documented. They can see pulmonary hypertension on echo, or they can have a cath lab, they can see what the pressures are in the right ventricle. So the PA pressure is super high, you can't use the PAD. If they have, otherwise, it's okay to use just the pulmonary artery diastolic pressure. The PAD it approximates your pulmonary capillary wedge pressure. Okay, pulmonary hypertension is going to have a really, really high, PA systolic and PA diastolic, like PA like 40/25, or like even 60/20 you've seen, even something like 70 pressures. Like that's the same pressure as their systolic blood pressure. What the heck, right? But then now what is on the left side? It's actually much, much less, right? So you can't use those interchangeably. If they have a lot of mitral stenosis, that might cause a abnormal, what can a wedge show you? It can show you, it's equivalent to your left atrial pressure, but sometimes when you have like mitral valve issues, it's not exactly what the left atrial pressure is. It's because that left atrial pressure is being modified by this mitral valve stenosis, all right? And then if it's not in the right zone, that might be an issue why you can't get a good LA pressure or wedge pressure. And you have high PEEP, just like CVP. If you increase the PEEP, that's going to increase your wedge pressures. Okay. So wedge pressure versus CVP, what is the difference? So it's the same thing as CVP. You're going to be able to see Canon A waves, right? You're going to see a loss of A waves and AFib. You're going to see AV dissociation. You're going to see mitral valve issues, mitral valve regurg versus tricuspid valve regurg on the CVP on the RA side, right? What are some other unique things you can see with the wedge? You can see that there is there is a over wedging situation. So if you have this value just going up and up and up and up, that's a sign of over wedging where the catheter has migrated deep or the balloon is inflated. It's one of the more unique things with a pulmonary artery catheter wedge pressure. All right. So the other piece is if you're like comparing to the EKG, it's a little bit farther past the EKG because it's reflected, right? It's like, was it, did the left and right atrium go differently? No, but you are listening via a cup and string, right? Via a reflection from the LA. So it is going to be more distant compared to your P wave. So here's a P wave for your right atrial pressure. There it is, like 0.12, whereas for a wedge pressure, it is about 0.18 to 0.20 away. Okay, but still A wave is after the P wave, V wave is after the QRS complex. It still follows that pattern. Okay, so this is just a summary of our CVPs and our wedges that we discussed in our CVP chapter, right? So the other thing you can tell with like right bundle branch blocks and left bundle branch blocks, you can also kind of tell that on the PA side because it's going to be reflective right there. It's just happening right there in the left atrium. All right, what's another situation? So with equalizing pressures, like my PA systolic is 25, my PA diastolic is 25, my pulmonary capillary wedge pressure is 25, and my CVP is 25. What the heck? Why is everything 25? That means it's being compressed and compressed and compressed, and you have a tamponade on your hands, right? So equalizing pressures is never good. Obviously, you're going to look, say, hey, my blood pressure is, is going down. Or you say, hey, my pressure requirements have gone up. I've added levotheta at 4, 8, 12, 16, 20. Look at that, it's really weird. My pressures on my Swan are all the same. That's a red flag for anybody who's experienced, like, oh, that's a tamponade. What are we doing here, right? And of course, you might see some JVD, but you have a CVP tracing, right? So you could, yeah, that would be high too, which we see. All right, so cardiac output. Okay, so our cardiac output is again, measured via this thermistor cable, plugs in right here, measure the temperature, and also we have a temperature plugged in right here on our catheter. And it's measuring the difference in temperatures between the RA and the pulmonary artery. Okay, so once you have the cardiac output, you can really see the world of hemodynamics. There's a lot of extra stuff you can get, all this fun stuff to get to see what is going on with the patient, right? You can see a lot of the values, they need a CVP to operate, right? For systemic vascular resistance, you need a CVP, or right atrial pressure, and a cardiac output to get a SVR. So you need to do your cardiac output to get these values, right? You need to have it based on their height and weight and gender, because a cardiac output of 8 for someone who's 6'5" is not the same for 8 for someone who is 4'10", right? So we have to base it on their actual indexed value and what it is based on their demographics. So that's what is based on the body surface area. So you just punch that in the machine, in the GE monitor, and it will tell you what their index is, right? So cardiac index, for instance, is 2 to 4 liters per minute per their kilos, per their body surface area, right? So what else? We have the supplies. Supplies a little bit different. You have a little cardiac output kit, and it has your syringe in it. It has everything you need. And the cable you have to grab separate, but you get your cable and your kit, and you get D5 water or normal saline. Yeah, not normal saline. You get D5 water because the formula, again, uses the molar mass of dextrose, not sodium chloride, right? So we get our supplies involved, and then we're going to then probably get a stopcock because we have our CVP hooked up there as well, right? And that CVP needs to sometimes be intermittently checked. So usually we do either cardiac output or CVP, one or the other, right? All right, so how it's done. So this area under the curve is calculated by this fun formula right here. And this formula is based on the length of the catheter, the lumen of the catheter, what the resistance is of the plastic. So there's all these coefficients that you have to enter into the monitor. So our coefficient is like 0.456 or something weird, right? I've written down on our IC homepage in case you ever forget. It's like, oh, there it is. Cardiac output constant is what you have to make sure you're entering inside the computer every time. So it has these different computation constants that you have to enter to make sure, because if I put this Swan versus the other Swan that has discontinuous cardiac output, they're not interchangeable. They have different coefficients and drag and other weird things that you have to calculate for if you're calculating such small changes in volume, right? So again, we're pouring in all this cold water, this 25 degrees Celsius fluid, dextrose, into the pulmonary artery, and we're seeing how fast it gets to the other side. And we can measure that over time. And use this fancy calculus to measure that area under the curve, and then we are able to get a cardiac output, right? So this in red is maybe a normal cardiac output. If it takes a long time to get to the patient, that's a poor cardiac output, right? What else? So they have a, there's all these variables that we want to make sure are limited, right? Make sure we're using dextrose. Make sure we're only giving, 5 to 10 cc's. The syringe, make sure we do that. The temperature. Sometimes they used to do iced fluid, but they found there's no difference between iced and room temperature. 25 degrees versus 5 degrees. 5 degrees cause a lot of arrhythmias, right? A lot of cold water going through the heart. It's going to cause a little upset heart. Okay, so we can tell by the rate of flow through the heart what our values are. And we get about 3 trials, and then once we get 3 trials, we take the average, and that's going to be our cardiac output. As long as it's within about 0.5 cardiac outputs, then you are good. Okay. So pre-procedure, you do all the data, put it all in there, assess if you are, make sure you're not giving pressors via that port. You're going to give 10 cc's of fluid push through, right? So that's not a good practice. You want to have another line or another port for our pressors and other things, right? So we're going to give 10 cc's of IV bolus push right away, really, really fast, over 4 seconds or less. It has to be very, very quick. Otherwise, it's like, oh, you got poor cardiac output. No, I just got a nurse who's really weak, right? So you want to make sure you're injecting really, really quick, as fast as possible. And while it's reading on the monitor, while you get this little reading on the monitor, you're going to then draw up your next value, right? You're drawing up your D5 water into our syringe right here. Let's turn the stopcock off, and then we're going to push it in again, get another trial, right? And then we're going to do the same thing, 3 trials, and as long as we're within about 0.5 liters per minute, then we can say these are good values, right? The cardiac output screen comes up when you hit the cardiac output button, right? That'll come up there. And if that doesn't show up, there's different parameters, different menus you can do to bring up the necessary screens you need to get your cardiac output. Okay, so 3 or more good waveforms. You can get rid of bad waveforms, like, oh, I was weak right there, don't nobody look, right? And you can delete that waveform, that's perfectly fine. There we go. All right, so yeah, plus or minus 0.5 liters, all right, that's okay. But if it's more than that, then you should delete that trial and try again. You just keep the 3 best ones that are within 0.5, right? And sometimes they're moving, sometimes they have arrhythmias, sometimes there's tricuspid regurg. I don't know, they probably found it out once they put it in, right? So there's other things that can affect our cardiac output, right? As the catheter migrated, right? That can, if the PA is now in the RV, that's not going to be a great cardiac output, right? If it's all displaced. So you can have hyperdynamic cardiac outputs, you can have really bad cardiac outputs. The normal waveform just looks like a little tide. It's going up and then coming down, right? It should be smooth, right? It should be a single peak. There shouldn't be multiple peaks. There's no variation for that, right? And you can always edit, delete curves you don't like. Don't be in there with like 15 curves and you're like, because that's a 150 cc bolus, right? So you want to make sure you're limited to like 3 to 5 pushes, right? Make sure you select save, otherwise all your work is gone. So once you get your cardiac outputs and everything, and it's punched in there, you like what you see, right? You enter your demographics ahead of time. You got your cardiac output trials. You got 3 of them. You hit save, or not, it's closed, sorry. You hit your edit settings, edit average. Sorry, my fault. Edit averages would be how you would delete trials. You would go to your numbers. So your numbers are over in your confirm cardiac output and calculate. So then you'll get brought to this screen here, and you can start getting all your numbers, all your fancy PVR, SVR, stroke volume, all those other things. And for an SVR, though, you have to need a CVP. So sometimes you have to punch in other values here. Like here it needs, how much PEEP are you on? Why would it want to know PEEP? Because if it's 10 or more, it's going to change my numbers by 3 points, right? And like my CVP looks like I already put it in on this one, but sometimes the CVP wants you to punch in as well. So you can edit the values and enter more values if you need to. Okay. Yes, as long as you hit save, it will link to the computer EMR. Okay. If you don't hit save, you have to take a picture of it with your phone, right? Otherwise, it's just I promise I did it. It's like, well, the way you did it is why you hit save. And then once you hit save, you can hit trends to then see what the last cardiac output, cardiac index was. See if we're getting better or worse. We need to add pressors, add inotropy, add vasodilators, all the things we can do to hopefully fix the patient's situation. Okay, so SVR, so that's used when we have a CVP, right? The formula uses CVP in it. So if we don't have a CVP, you can't get an SVR. So you can't get SVR if you don't have a cardiac output either. So you need a cardiac output and a CVP, and then you can start getting an idea of their systemic vascular resistance. How much resistance is there on the other side of the heart, right? You can get the PVR as well, right, from this. PVR is also calculable, but putting all this stuff together can tell you if they need more vasodilation, for instance, or they need more vasoconstriction. On the flip side, maybe they came back post-cardiac surgery and they have all this inflammation, and all the inflammation is causing this super wide vasodilation. It's only SVR is only like 400, 600. So, well, shoot, let's add some more inotrope, let's add, or some more vasoconstriction. Let's add Levophed, for instance, because I know Levophed will increase vasoconstriction. It'll also help my heart a little bit when I get a little higher doses. Okay. And yeah, you can get the index values, just FY, for when you're getting, you can flip between them, what the actual values are versus what it is for this patient's demographics. Okay, when you're taking a catheter out, it's the same as a regular procedure where you're taking a sheath out, right? If it's femoral, you're using a femstop, right? If it's jugular, you're applying a lot of pressure for a while, right? And again, you have to make sure you have good values, right? Good PTTs, good INR, good platelets to make sure we're not going to have a bleeding situation on our hands, right? Again, before this though, you want to make sure, sometimes they take the Swan out and the cordis is just left in there as IV access, and it's just, there's nothing TKO going. So you want to make sure you always have fluids running through this guy. And they'll put a little end cap on it. The problem is that the end cap is in the kit for insertion, and if it's 5 days later, nobody can find the end cap. So you just put one of those regular IV claves on it, you know what I'm talking about, little negative pressure guys. That works too. Okay, so where to go from here? So we're talking about shock in our next lecture, I believe, right? So we'll be talking about a little bit about the changes in hemodynamics. What happens to the SVR? What happens to the cardiac output in this shock? What happens to the cardiac index in this shock? Is it going to go up or down if I give this medication? Do we give inotropes or give inodilators or inopressors? Do I give pure vasodilators or pure vasoconstrictors, right? So that's kind of the next step. You're putting all this stuff together, and you can tell if someone has a heart failure with HFrEF, right? That's decompensating. All the fluid is not going forward; it's backing up. Obviously, my cardiac output is poor, and obviously all my pressures in my lungs are high, and my CVP is high too, right? You can tell if someone has has distributive shock. You can tell if someone has neurogenic shock. You can look at all of these things and put the whole piece together, right? So that's what the utility of a shock is as well. When someone has combined shocks, someone has really bad CHF, and they're here for septic shock. Well, how do you know which one it is? Which one am I treating? Which one am I going up on? So that's where a PA catheter can help, right? And again, just a recap on the setup, where you know the markings, make sure the waveforms are okay, and then you shoot your waveforms, your wedge, and you shoot your cardiac outputs, and then you're able to get all of our fun hemodynamics. All right, so that's it for hemodynamics.